Well, welcome, Mark. Thanks for coming back to have another discussion with us so quickly after, I think it was about 10 days ago when we first looked at the vaccine. Mark, I hope people will have watched the first video. If not, we'll put a link onto it as well. But could you, for those people who, again, you'd be new to them, just explain why we're speaking to you, one from the vaccine perspective and your engagement and activities in pulmonary hypertension?
Yes, of course. So I'm Mark Toshner. I'm a university lecturer in Cambridge and also a pulmonary hypertension doctor. I work in Royal Papworth Hospital in the Pulmonary Vascular Diseases Unit. But I'm also the local investigator for the Oxford vaccine trial. So I've been helping to coordinate the enrolling of volunteers, the administering of vaccine and the safety follow-ups in the Oxford trial in Cambridge.
Mm-hmm. Good. So Mark, since we last talked, one of the vaccines has received a license. I think that'd be the right phrase. The Pfizer, that's the Pfizer vaccine. This is not the same as the one that you've just talked about that you're involved in as a local investigator, is it?
That's right. Yeah. So as most people know by now, the Pfizer vaccine or the Pfizer BioNTech vaccine is what's known as an RNA vaccine. The way our vaccine works is that we use basically a common cold, and that's a chimp adenovirus is the technical term for it. And within that common cold virus, we've inserted the gene to be able to essentially fool your cells into making some protein. And the way that our vaccine works is similar downstream to the Pfizer vaccine. The Pfizer vaccine just misses out that interim step and directly gives the RNA, and that's the message that the protein gets kind of made from, and it gives it directly. Okay. So RNA is a very short-acting molecule that is how DNA makes proteins.
Now, if I ask you any questions, Mark, that are unfair and difficult to answer, then just say that's unfair and difficult to answer. Thinking now in the media, there's a few questions that's come up, and we touched on this very clearly, and you articulated the answers very well, but I wonder if you could revisit these. That again, the vaccine seems to have come along very quickly, whether it's the Pfizer one or the Oxford one. Why again are we in a position where we've got vaccines quicker than we probably would have had not that long ago?
Sure. It's people's major concern at the moment, and it's a valid one, but it's addressable. So the normal process of drug and vaccine development is just slow, and it's slow because there's a lot of red tape, there are difficulties with funding, and then just running trials is a painful, difficult process. So the normal timeframes aren't there because of safety. In fact, very rarely do those normal timeframes have anything to do with safety. They're just there because the real world is frustrating and has barriers. And what's happened in the last year is that all of those barriers have just been removed. So the euphemism I've been using, or the metaphor rather, is that it's a little bit like if you sit in traffic in London and imagine if somebody just got rid of all the cars, turned all the lights from red to green, gave you the fastest car they could, and then gave you a police escort to make sure you're safe. That's what's happened in this last year. So we're really lucky. We've got this wonderful trials infrastructure in the UK, and that trials infrastructure was just basically pointed at vaccine studies very clearly from top to bottom. We were given as much money as we needed, and all of the usual simple little barriers were just basically swept away from us. So the speed of it has absolutely nothing to do with safety. The safety processes were exactly as they were always were. If anything, they were probably slightly higher, because no trial in the history of in fact, I don't think of any trials has ever been as carefully watched by the whole world as our trial and the other trials. So we from within the trial were very aware of that, and so the focus within the trials on safety was absolutely laser-like, and I'm incredibly confident that the Pfizer vaccine will have been through the same process, as will all the other vaccine studies.
What allows a vaccine like this one, the Pfizer one, to get a license? What does it have to achieve, Mark? Is it pure safety? Is it effectiveness? What's the primary things that we're looking for?
That's a good question. A lot of people won't understand the process. So the therapies are assessed by an independent regulator, and that's the MHRA. So if you speak to any investigator who's ever been through any part of the MHRA process, if you mention the words MHRA and inspection, that is enough to bring you out in a cold sweat. Yep. They are professional pedants. And they're people who absolutely and utterly love detail and are obsessed with safety processes. So they essentially go over all of the trial data, and the questions they will be asking themselves are, was the trial well conducted? Can we have confidence in it? Is the therapy effective? Does it work? And they pre-specified what their bar would be for that before we reported. So everybody knew what effective meant before we got to of having trials. And the third one is the safety profile acceptable? And these are not hard and fast things. They vary from disease and therapy, to disease and therapy. And if you think about pulmonary hypertension, we have a number of different causes, and we have a number of different potential expectancies for the implications for things like side effects in life. And often what you will balance off in your assessment is not just the safety of the therapy in isolation, but the safety of the therapy in the context of the disease. And that's really important here, because with vaccines, you're delivering it to everybody. So actually they have to pass a safety bar that's miles higher than anything I would ever have to do for a pulmonary hypertension therapy or a pulmonary hypertension trial. But you also then have to compare it to the effects of actually getting disease. So when they come to a decision about, is it safe, it's an incredibly high bar. It's really like an unbelievably high bar, but it is not judged in isolation. The question you have to ask yourself is this a vaccine safe? But also, how does it compare to actually getting the disease?
Okay. One question has been levelled, or people have levelled at me, I think in a healthy way, is that why is it that the regulatory authority in this country has approved before any other country? Are our standards the same, worse, better? It's a genuine question.
Yeah. So I think that the UK is a world leader in the regulation around therapy safety, and that's a well-held, widely held opinion. There are, in some other countries, some significant political pressures on the regulators. And so each country has a slightly different calculus over the regulators' approach to the same data. I have no qualm about how our regulators will have assessed this, because I know how good they are and how independent they are. But there are other countries where the calibration of those decisions is slightly different. So for example, in the UK, we generally sit at the higher end of vaccine confidence. So if you look at surveys, international surveys over the years, we have trust, in fact, in the general population in vaccines and in our regulators to get this right. But if you look at somewhere like America, that trust is much, much lower. And therefore, one can imagine a situation where the regulators have to be approaching this in a different manner, because the population they're speaking to is different. So I'm not worried about the fact that the decision was made quickly. I trust the regulators, but you don't have to have the same level of trust that I do. That's okay. I think we all come from a different position. The likelihood is that the majority of people are not going to get a vaccine for quite some time, even though we have a licensed vaccine ready. And that's because of the way we will have to approach giving vaccines to the whole population. So you can sit and wait for the data to come out. Some of the data hasn't come out yet, and you can make your own mind up. And you can, if you're not comfortable assessing that data, get someone you trust to explain it to you and make your own mind up downstream of that. I am very powerfully against mandatory vaccination. I think that's not what's going to happen, and I don't think that we need to be talking about it. We have months for people to satisfy themselves that vaccines are safe. I am satisfied right now because I ran a trial and I saw the safety process from the inside. But most people don't have that privilege. So I'm confident in both the safety of the trials and the approach of the regulators. But if you haven't reached that level of confidence because you don't have that inside knowledge, wait, see the data and gain confidence from seeing other people get a vaccine.
Okay. You raised a really good point there, Mark, to segue into how the vaccine and vaccines will be rolled out, that not everybody, it's not going to be done alphabetically, there's a priority. How's that been, and from your clinical perspective, just talk to us about that and give us confidence or critique it?
Yeah. So I think this is the thing that we wanted most to talk about today, because obviously for the pulmonary hypertension population, the pressing question is now, when will I get a vaccine, and should I take a vaccine? And so I think we have an answer to one of those questions, but the other one is a little bit grayer. So that should I take a vaccine? My advice to you is unequivocal yes, because we don't yet really fully understand the risk of pulmonary hypertension in the context of COVID. There is some data that suggests that our patient groups are at increased risk. And I think if we're doing the least risky thing, it is much, much safer to have a vaccine than to put yourself at the risk of getting COVID. So that's simple. When you will be offered a vaccine isn't simple. And that's because it's going to be a really complicated process vaccinating a whole country. And I think we're only at the start of realizing how complicated it's going to get. So for example, last week, in fact, just a few days ago, the plan changed. It's already changed before it was implemented. The original plan was to have healthcare workers first with over 80s and vulnerable over 80s in particular, nursing homes in a kind of parallel group running just behind. And that has been reversed because of the decision about who is felt to be most vulnerable and what the most safe way to do this is. And it's likely we're going to see some slight changes as things go along, but also as we hit the practical barriers of how do you ensure that you set up rules and then follow them. And my expectation is that the pace will slightly vary from place to place. If you think about it, this isn't like the Ryanair queue in an airport. You don't have a priority lane where everybody's going to go through it and then we're all going to wait and then come through next. Some centres are going to be more efficient than others, and some local decisions will be made about the applicable practicalities of some of the general rules. I think overall it's likely that the pulmonary hypertension group is currently in the sixth tier. That's the 18 plus with a comorbidity that makes them vulnerable. And that probably means we're looking at weeks to months before the vaccine rollout in that group. But I think right now it's difficult to judge. It's a really complicated thing. It's coming. The exact timeframes I'm not sure, and I wouldn't overstep and say that we have complete clarity over that.
Yeah, sorry about that. Can I just say, we're doing this on a Sunday afternoon from home, so I went on to mute because the dog's barking at the Amazon man delivering. So apologies for that. So I'll start that one again, Mark. One of the things that you actually said there, Mark, is that this changing, what was agreed or what was the intention 2 or 3 weeks ago has changed because we're learning different. We're understanding the things differently, and the logistics is an enormous logistic of getting the vaccine into the population. But there is real reasons, and there's a clarity of when people should get the vaccine. Okay. Do you want to just mention, Mark, in pulmonary hypertension, we talked about the condition itself, any interactions with the tablets, the medicines, the drugs that we use in pulmonary hypertension?
Yeah, super question. So I think the history of vaccines is that they don't interact with drugs. So it's really rare as hen's teeth to find any interaction, and that's because they're not medications like you classically think of. They're also incredibly short acting. Studies have not specifically demonstrated yet the current vaccines and if there are any interactions. So because of, in fact, actually often vaccines don't do those studies, but we're going to get information into that rolling in with time comes. I expect these vaccines will be no different than previous vaccines. And so I don't expect there to be any drug interactions. But one of the good things about the setup in the UK is we have a very well matured tertiary approach to looking after pulmonary hypertension. So that, as you know, they're all in specialist centres, and it's something we'll be able to evaluate from the specialist centres, and it is something we'll be keeping an eye on. So I think I can offer reassurances, but we don't actually have clear data. Historically, vaccines just don't interact with therapies. It's just not recognised.
We've talked so far, Mark, about, we've mentioned the Pfizer one because that's been in the news and got a licence, and then the Oxbridge one. Any idea when the Oxbridge one might come online, get to the point of approval, or is that difficult to say at the moment?
I think it's going to be weeks. So the data's with the regulator right now, and that's in the public domain. Remember, our trial's different than the others. Our trial wasn't a drugs company trial. Our trial was an investigator-led trial. That is an important distinction, partly because it just means that this wasn't. If you have anxiety about drugs companies and about their agendas, we were completely independent. We had no interaction with Pfizer during the trial. Pfizer had no control or input into the trial and didn't get the data until the very last moment when the trial was closing. Now, the only reason they've got the data is because they are experts at putting the regulatory submission together. That usually requires a completely expert team, and just investigators, we don't have that kind of resource. So the data gets packaged up, given to Pfizer, and the Pfizer then put the submission in, and they will then take forward. And that's because, again, scaling up on an industrial level requires a commercial enterprise. That's all important because what's good about the vaccine that we worked on is that from day one there has been a commitment to provide it at low cost, and so that means that there will be a variety of options for the whole world, and not just for those that can.
I didn't realise that, Mark, that it was independent of that. So that's in some ways is a reassurance, because it is one of these media stories on social media, etc. That's really helpful to understand, and the difference.
I mean, I've actually had to state, in some of the articles I've written, that I have no skin in the game here. I didn't get paid to do any of this, and neither did anybody else that was in the trial. I also have no funding or no particular ties to funding bodies for vaccine. I've never done vaccine studies before. I won't do them again after that. This is too hard work. So I think I am a little bit independent. I mean, obviously my bias is I was involved in the study, so I have an emotional attachment to it. But I like to think I retain a bit of independence here, and that independence extends to the fact that this was not a drugs company sponsored or run trial. So we were able to make completely independent decisions, and that's why our trial looks a little bit different than the other trials as well. So some people have kind of complained or raised concerns about some of the decisions that were made in our trial, about how it was set up. That was because it was a completely drugs company independent venture. So our decision making is not the same as a drugs company. We're not throwing unlimited money at this, and we had although we had a fantastic resource for it, it was delivered in a much more in a way that perhaps your patients in Sheffield might recognise, because in pulmonary hypertension there are differences between trials that are run by centres.
When we've got 2 or 3 or maybe even more vaccines eventually, how will we decide which is the best? I want that one, or I want that one. How do we get to the point?
So I think it's horses for courses here. There's no single answer to that. It'll be a mixture of practicality. So what do we have? What do we actually have in doses? How easy are they to get out to the general population? So, for example, the Pfizer one, as everybody knows, has big restrictions around its cold chain transport, and that's where it can be kept at any one time in its life cycle, and often it needs to be kept in a very cold freezer called a -70 or -80. That's not the case with some of the other vaccines like ours, for example, which has a reasonable amount of time that it can be left in a fridge. Then there's going to be the question of what's the definition of works, and that's something that I think we haven't communicated really well. I think there are different definitions of works. which might surprise you. To me as an individual, the most important thing is, am I going to get severe disease? So in the end, as an individual, what I really want to know is that I'm not going to end up really unwell. You know, that's the single most important thing to me personally. Then maybe the next thing after that is, am I going to get unwell at all? So am I going to get mild disease? And that's actually what we're looking at in most of the reported figures. So when you see those figures of 90, 95+%, that's about mild symptoms, not about hospitalizations. And we may find there are differences in the trials as we go through in their effect from that perspective. The next thing is we want to do is get down to the point of affecting asymptomatic disease and transmission. And so there are different definitions of works, and it kind of depends on your kind of value system. If I'm a 75-year-old with heart disease, diabetes, works for me might be the most important thing is I don't get hospitalized and have a risk of death of 1 in 4 or 1 in 5 or 6. But if I'm a 30-year-old, maybe living with an elderly relative who is at risk, the more important thing to me might be actually I just don't want to pass this on to my mum, to my dad, to my relatives, to my friends, or to my patients. So I think works is more complicated than just that number, and it'll take a little bit of a time for us to have a clear idea if there are differences in how the different vaccines work across those different domains. Ultimately, we're in a brilliant position because in our wildest dreams, we never thought we'd be talking about 90% effectiveness in any of those domains. So actually, this is the fact that we've got any vaccines that have hit that minimum bar of 50% reduction in mild to severe disease is an astonishing achievement. And I'm less worried about the kind of subtle details of it, but I think it's going to be a combination of what can we do in practice and what does the individual.
So that explains something in my mind as well, Mark, because I'm not going to tell you which study I'm in, but I'm actually a participant in one of the vaccine studies, and I've had an email today saying, thank you very much. Questions, but the study's continuing. We've not stopped the study, so actually continuing with the weekly swabbing and things like that. So it's not, here's a vaccine, close your eyes and just take it. The studies continue.
Yeah, and I think that's right. I think one of the big risks now is that everybody thinks this is finished and that we just move straight to licensing and everybody gets vaccinated. There are big unanswered questions. We're probably going to need to do comparative studies to look at one vaccine versus another. We might have to look at multiple vaccines and so doses of vaccines given together from different companies. We're going to have to look at long-term effects. So how long does the immunity last for? That's going to be really important. We don't know that yet. We don't have enough data on it. So the altruistic, wonderful people out there who all, like yourself, volunteered for an experimental vaccine were amongst the best of us. But what we now need is some more people to put their hands up and say, actually, even though their vaccines are coming in a few months' time, I recognise that there are still questions to be answered, and that these trials still need participants. And that's going to be a big problem, I think, because the more vaccines we have, the better. The more evidence we have, the more confident we can be. But it's going to be challenging now, I think, to enrol in some of the studies that are open. And so although it is absolutely an individual's choice, you can, as you know, Ian, withdraw from the study anytime you want. And there should be no pressure on you to stay in that study. It's always voluntary. But the more data we're able to accumulate, the likelier we are to have a safe and diverse set of options further down the line.
I mean, therein lies one of the big questions, isn't it? When do we get back to something like familiarity or normal? It's not going to be January and February, is it? It's going to be longer.
No, it's definitely going to be longer than that. And I know there's a lot of people out there confidently predicting when. I can't put myself in that camp. If you asked me to guess, I would think that in 6 months' time, we're definitely going to be in a position where life looks much more normal than it does at the moment. So there's definitely a light at the end of the tunnel, but we still have a bit of tunnel to get through before we get to it. And that 6 months might be shorter, it might be longer, but it's going to be made.
And having done 9 months of what we've had to go through to protect each other, 6 months actually these days seems, yeah, bring it on in a way. There's a reassurance on that one.
You say that, but the grey hairs in my head tell a different story. So yes, I mean, I think most of us, when we look back and reflect, will probably be astonished that it's almost 10 months now down the road. It kind of feels like it's been forever, and it's gone in a flash in the same instant. We have something to aim for now, and that's the difference. Whereas before, we just had a lot of uncertainty about what the future held. I think we know the path here now. Vaccines are going to reduce the frequency of disease. We are going to get back to a normal. It might not be quite exactly the same as the normal prior to the pandemic, but we're going to get there. And it's really just about us having solidarity as both communities and as a country to get to that end point. And I know that's challenging. It's challenging for everybody, but at least we now know that there is a link.
So Mark, I'm going to bring to you soon because I can hear the children in the background and they're being very patient, and thank them when you go to lend them Dad for half an hour on a Sunday afternoon. Really grateful for that. Key messages at this stage, Mark?
I think for the pulmonary hypertension community, the key message is that just keep on doing what you've been doing, and I am very confident the vaccines are going to be safe in my patients, but I also recognise that there's a lot of anxiety out there, and that some people aren't at that point of being ready to say, I'm going to put my hand up and have a vaccine, and that's actually okay. You've got time. You go and get some good counsel, go and speak to people you trust, wait and watch as the rest of us get vaccinated. Don't close your mind to it, and when the time comes, I trust my patients to make a good decision.